I can do. Thank you to my tutors in the back. So, today is Surveillance Day. And so this is our schedule for the day. We will first discuss expectations a little. We will then go into surveillance basics, or just an introduction. And then I will give you 3 case studies. And none of them are from Thailand, because I have not worked in Thailand. But you will be doing case studies in Thailand later today as we work through the process. So we'll have evidence-based medicine. I just put that as shorthand, hopefully. And which will help lead to the laboratory tonight. And then we will, the whole group, after lunch, we will go through a surveillance example together. So that will be group participation. And then you will break into small groups and design surveillance systems, drafts. They do not have to be complete and publishable today, but draft surveillance systems and then report to each other at the end of the day. And we will show you the mechanism by which we do that later. So the idea is that we get introduction to surveillance, we get examples, and these are 3 examples that I have worked on for the last 10 years. So they're fairly well developed examples. And then talk more about the evidence-based approach. Work all together, work in smaller groups, teach each other. Okay? Does that make sense? Okay. So I just wanted to have 1 minute of discussion. Watching your yesterday, the evaluation at the end of the day, it was very good and exciting to see how much everyone wanted to learn. Now it's time for me to remind you that this is a 4-day workshop, and that yesterday you outlined an entire master's in epidemiology in terms of what you are interested in. So remembering that the point of this 4-day workshop is to expose you and give you practical applications of epidemiology from a One Health or from a wildlife perspective as it integrates into One Health or big team kind of epidemiology concept, right? So we cannot teach you the level of depth in some of the things that you were interested in just due to time. So I would encourage you, if you are still interested, 3 days from now, there are many ways to get more training, and many of your colleagues have already gotten some of that. And there are other ways to get more training that we can discuss. And certainly we're here to help facilitate and discuss anybody interested in doing more EPI into the future. Okay? So you may not get the depth that you want in each subject, but that's due to time, because we need to get through the different skills in the different areas, which will make you good collaborators in 4 days. Then we'll find ways to go deeper if you wish. Okay? Are there questions about that? Concerns? You want to throw me out and yell at me? No? Okay. So I can go then. All right. Thank you. Okay. So just a reminder of what we talked about yesterday. Today, surveillance, tomorrow, outbreak investigation, and then risk analysis. And how they are linked. Do you remember this graph? And do you remember the story that I told you with this graph? Where this is a way to collect data that helps run models to answer questions about health for policy decision makers. That rarely is the first time the end result, but it is an iterative or cyclical process of updating and improvement. Right? Everybody remembers that concept? Because this is very important. We'll discuss this in terms of all of these modules for the next 3 days. So first, a few definitions. And this is straight from kind of WHO human health, but is probably as good a definition as any. The ongoing systematic collection, analysis, and interpretation of data, closely integrated with the timely dissemination of data to those responsible for preventing and controlling disease and injury. So one thing is we concentrate on infectious disease. There's surveillance for many different things, right? But we're just concentrating and focusing on infection right now. Timely dissemination. So collecting information and giving that information quickly to those who need to act. So it's to provide scientific and factual information for informed decision-making and action. And it's to help guide interventions, right? These are all very important concepts. Because when there are limited funds available for programs, you need to select based upon the best criteria for what you need, which programs to focus on. And most of the time, those are programs that need action. Okay? Now, that's not all of the time. So there is different definitions between monitoring and surveillance. And this comes from the dictionary of the OIE, the World Animal Health Organization. And so the difference when many people talk about monitoring versus surveillance is that monitoring is watching an ongoing process, right? So you know that you have tuberculosis in a district or a region, and you are watching that levels go up and down. It's often to assess how control measures or management programs are working, vaccination programs, things like that. Whereas surveillance, and it's usually for endemic or diseases that you know exist, right? So surveillance, on the other hand, is more focused on something that you find that you now need to react to, something that needs action. Now, many people use different definitions for these terms, so realize that this is not the law of definitions. But this is according to OIE, which is our veterinary global standard setting body. Okay? So reportable diseases are usually, actually could be in both. Some reportable would be under monitoring. You're watching the amount of rabies, or you know that there's diseases like emerging diseases like Ebola, and one case is reportable, and you need to act on it. So, right? So there's different uses of these terms. This, if you have not seen this, just accounts for the total human mortality, annual mortality, and it just shows the percentage that is infectious disease, and then breaks down infectious disease. You can find this every couple of years on the WHO, World Health Organization website, but it's just to show what piece of the pie, of the cake, that infectious disease has, and we're going to focus on infectious disease type surveillance today. And I don't know if you can read those, but respiratory is the highest, HIV/AIDS was second, and this is global. Diarrheal disease, tuberculosis, childhood diseases, malaria, sexually transmitted diseases, meningitis, hepatitis, tropical parasites, dengue, and other. Okay? So the reason that we talk about that is that these become the priorities for programs on a global scale. And those priorities are then implemented by what's called the Three Sisters. You know these guys? You know WHO, you know FAO, you know OIE. Okay, so we don't need to do that. But they set standards, as you know, then, global standards, which then ministries follow and participate in those global standards, which then implement at district level, right? So the global surveillance or the global monitoring of these is coordinated. And just recently, these three have started to talk to each other and coordinate more between each other. And it's amazing that for a long time they did not coordinate a lot, but they are trying now. And there are documents that you can find on their coordination and partnership strategies. So just to highlight the websites and the programs that for each of these for global surveillance based upon their reportable diseases, right? So this one is for WHO, and you can easily find it on the web and find a lot of information on this, but this is their overall program. And then IDSR, have you heard of IDSR? Who here has heard of IDSR? Okay, only one or two. So this is a program that started in Africa between the CDC in US and WHO with the local African governments. And it is an attempt to work on the timely part of this, right? So it's an attempt to connect laboratories and surveillance systems quickly with outbreak response. So it's an attempt to speed up the reaction to response. It links surveillance and response. And now it has been initiated more globally, and the Southeast Asia, I can't remember the whole acronym for the WHO working group in Southeast Asia, has taken this up and has a report, I believe last year or the year before, about the implementation of this system as well. So the interesting thing I find is that everybody talks about One Health right now, but in none of these documents do you really find wildlife. They may talk about reservoirs of disease being wildlife, but they do not talk about the systematic incorporation of wildlife into these programs in their documentation. Individuals may talk about it. Yet they all go and they talk about One Health, and yes, we need One Health, it's so important. And it's not included necessarily in these documents, these implementing documents. So we have a long way to go internationally to get One Health embedded in the international culture. This is just their schematic for IDSR, and it's to show that the goal is to go from community all the way to global, right? So the idea is that H5N1 happens in a small community, and that information gets all the way up to a global level, and response networks happen both locally and globally to that. So it's a very ambitious program, but there has been very good success measuring the implementation of this in some countries already. They've been doing it in Africa for quite a while. Okay, there are a few success stories that they like to brag about from the WHO, and they published these. And these should all look somewhat familiar, I hope, to those interested in emerging diseases. One of them should certainly look very familiar, but they list SARS as a great victory for this kind of system of syndromic surveillance, where a flu-like illness was caught very quickly because it was spreading so quickly and it looked a little different. And they talk about the international coordination for control. And then they use your country as an example, where the FETP graduates were working on household surveys and were the first to kind of show the person-to-person transmission risk. And they updated all the education materials around the globe based upon these FETP people who were back to work in their areas. And then the other is Ebola in Uganda a few years ago, where a second-year public health student had learned about surveillance, had learned about reporting and IDSR, and went home to the district and saw unusual occurrence of many people at the clinic and very bad clinical signs, and it was very unorganized, and he reported to the Minister of Health in Kampala, and that simulated a large response and probably saved many people. So, interesting case studies that they have that I was not a part of, so I will not present in detail, but they have published, and if you have not read them, they're good ones to read for examples. FAO, we had some EMPRESS talk yesterday. So EMPRESS is the system for FAO for prevention and early warning. We all know, I think, that FAO is food safety and agriculture based, right? So this is very much has both zoonotic diseases and agriculturally important diseases for food security. And they've got a very good website. Have you seen this? Who here has seen the EMPRESS website? Okay, I encourage you to go look at these and see how they design their global systems. But there's real-time, there's quick reporting. I don't know if it's real-time or not. But then they also have a map, and sorry that doesn't show. But this is avian influenza and part of their current map for reported cases. This is the normal Asia and Africa and Europe and Middle East map. So this is a very good source of information of global concern. And it's nice for veterinarians because it has things that we care about that are not necessarily public health concerns as well. And then the OIE. Everybody knows the OIE website? Who here has been to the OIE website? Okay, homework. Everybody find these 3 websites, and we can list them. You'll have these slides. As people concerned with global emerging and zoonotic diseases, you need to know where the important sources of information are. And these 3 are a very good start, besides your ministry information and the obvious places for Southeast Asia that you probably are more aware of, and then your country in general. Okay? But these are important things because as wildlife professionals that are both arguing to be included as important in One Health, but also will be required to be a part of the system for One Health, you have to be able to integrate into the international world and know how this game is played, know how the system works, know where the information is, know the agenda and the politics of where these people come from when they come and interact with you. And this is the best way to educate yourself. So the World Animal Health Information System is the OIE's monitoring and surveillance reporting system. There is a public part of this, but then there is also a login secure part of this. Does anybody know who the representative, not his name or her name, but the position in the government that represents Thailand at OIE? Who represents you at OIE? There's all the member countries have a representative who come to vote on the committee. Who is your representative? Anybody? I'm sorry, I'm deaf and there's air conditioning. So the Director General of the Livestock Health Department, is that what it's called? Okay. So in our world, that would be our Chief Veterinary Officer. So he's your head veterinarian of your ministry that is involved in agriculture and animal health, right? I mean, is that the same? Okay, yes. So each country, the representative is the head ministry veterinarian of whatever, and they go every year and represent the country at the Congress that creates international standards for animal health. There is now a wildlife working group of the OIE as well. And so wildlife has been officially incorporated over the last maybe 5 years into the OIE, which is a very large new development. So you can go to this website and find the wildlife information, the wildlife reportable diseases, the wildlife fact sheets for diseases, the wildlife reporting in the node. Okay? Now, the secure part of the website, only your chief veterinarian can get to because it's secure information. I'm not sure why, but anyway. The other thing I should say is Empress now includes the wildlife unit, right? So we heard from Borapat yesterday, who has been working with FAO and wildlife unit, and I don't know if you've met Scott Newman or Tracy McCracken. Yeah. So these are people in the FAO wildlife unit, and so 2 of the 3 have wildlife included now. Both of the animal groups have wildlife. The WHO does not yet. They rely more on OIE and FAO. Okay? So those are the international standard players. And it's good to know them, as I've said. So your homework is to go check out those sites. Read them, you learn much information. Okay, so this is the template for how we are going to talk about surveillance systems. And we have a handout that you can keep with you for today, because we're going to refer to this template over and over. And I'm going to go through these things, but these are pieces of a surveillance system. It's not every tiny, small piece, but it's the basic groupings, or the basic categories. And they are chronological in a logical format.
Thank you.
So you can see that surveillance systems have an objective. You must list the objective. It's like a research project. What is the question or the hypothesis? And you need to know under that who cares about the data, who will use that data. We'll do examples. It has a methodology, and we'll talk about that. Sample collection standards and protocols. You've done that in other workshops already, right? Where you talked about how to go get samples, immobilization. How do you collect samples from wildlife? How do you preserve them? Things like that. So you should know a lot about this one. Diagnostic standards. Health information and management system. How do you keep your data? We'll be talking about that this afternoon and tonight. What is the result? What is the action of the reporting? Why do this? Why do we care? What will happen? There's both political and real health concerns about this. And then there are evaluation systems. So this is, again, a pseudoscience. It is scientific, but it is not always necessarily hypothesis-driven. But there is a methodology, and there is evaluation and measurement for that methodology. And we'll talk about that. And then, of course, there's cost-benefit. Things like how much does it cost, how much money in this system equals one positive case? Is it $2 US or is it $10,000 US? And is that cost efficient? So we'll talk about that. It's very important in wildlife. It's very difficult for us to get funding. We need to use our money very, very wisely. Okay, so we're going to go through each of these in a little bit more detail for relevance. So objectives or utilities of surveillance. There's a nice document, and I have some, we'll discuss how to get you some of these book chapters or documents that are nice overviews. But one of them I very much like talks about the objectives for immediate detection, for periodic dissemination of information, and for storing information. Right? So a good system will help you do things immediately. It will help you every quarter, every few months, every year, give annual reports on the basic status of the situation. And it will help you store information long-term for retrospective studies later. Okay? So obviously for immediate detection, we want to detect epidemics, emerging problems, understand changes in laws or practices, looking at resistance as it occurs, looking at distribution of populations at risk, how people move, immigration, emigration. So those are all immediate, we need to do something, or they're important emergency concerns, or potential emergency concerns. And then the periodic dissemination is just your basic reporting, your planning for public health, for wildlife priorities, for agricultural systems, things like that. It becomes somewhat obvious. You will get these slides. And then for storing, it's good to have, if you want to go back and learn about the natural history of SARS, it's probably good to have all of the data that you can access to look at all of the test results and all of the surveys that were done for SARS to look at the natural history over time. Many people have published that already, but if nobody has, then, and you want to go back, so say you want to look at FIV in tigers. I'm making that up. I don't know if tigers have FIV. And that's not reported to an international community, to your wildlife authorities, but you want to do a natural history survey. It's good if you can go back to that database, get that data, and do that natural history, right? This is very important for wildlife and ecology. Looking at research priorities, validation of new diagnostic tests, have archived samples, have results from the old diagnostics. Very important to have these archives. Okay, so a lot of this is obvious. Methods. Who here has heard of passive versus active surveillance before this minute? Okay, very important piece of how people describe surveillance. Passive is taking advantage of what already exists. So, laboratory data. Things are sick, things are dying, they're sent to necropsy, samples are sent to the laboratory, they have all of that data in their database because they're just the results of those diagnostic cases. If you coordinate and collate all of those results, you would be doing passive surveillance. Nowhere is there a study design, these are just cases coming in. Often, people don't even summarize. Laboratories may give you an annual report or a quarterly report, but there's a lot of data. Same thing, so laboratory necropsies and hospitals are three really good sources of passive surveillance data. There is no purposeful statistical design, and most of the data happens conveniently by just whoever submits. Okay? Very important. Usually the easiest kind of sort of preliminary data for us to get. The first place we look is in the necropsy records. Is there any information on that? If there is no program. Active surveillance has a study design, has a statistical basis for why you sample, and it has a strategy for going out and collecting those samples and making statements. So it has a hypothesis. Sometimes it's freedom from disease. We do not have mad cow disease in Thailand. And we check our abattoirs and we test a significant sample of the animals that go to abattoir and they're negative. Therefore, we can state that we do not have, so freedom from disease is a big purpose for this. Looking at control strategies is another big reason for active surveillance, right? You want to say with confidence that this problem is getting better. So we're designing a study to go out and test the appropriate things. Prove to me that gibbons do not have tuberculosis. Is there gibbon tuberculosis data in Southeast Asia? A database, a surveillance system? Maybe there's some necropsy data from projects, a little bit of passive data. But we would have to design a study to know the population, know what percentage of the population we have to sample, and the way to go do that. And that may be an example that you use later. Maybe not. We'll see. Okay, is that clear? Very important first distinction. There are other definitions, again, of active. We could talk about active for a long time, but those are very basic definitions. Okay, there are other methods of surveillance. So syndromic surveillance is important. So active or passive system that uses case definitions that are based entirely on clinical features without any clinical or laboratory diagnosis. So examples are fever of unknown origin. This is big in public health, right? WHO. So this, a lot of times, is everything gets diagnosed as malaria. And what are all the other things that would cause fever that are not malaria? And why? So I don't know if this happens in Asia, but in Africa, this is a big problem. Everything is malaria, and diagnostics are not available, and so they don't know the differentials for all of these. So this is a syndromic surveillance. Respiratory syndrome, so influenza, right? SARS was discovered through syndromic surveillance for respiratory disease based upon influenza. It didn't look like influenza. It was influenza negative, and so they did more investigation and found the coronavirus, right? Diarrhea disease. So maybe there's a reporting system for cholera. And maybe if it's not cholera, there's no diagnostic done extra to figure out what the diarrheal disease is. So this would be kind of an example that I know in South America is very prevalent. A lot of times they worry about cholera outbreaks, but they don't do the diagnostics for anything else. Okay? Bioterrorism is another area that syndromic surveillance is very popular. Very trendy. Okay, this is just it doesn't show up well, but some syndromes and an example that we did looking at in Africa to try and break down some syndromes. So chronic febrile systemic illness. These are the symptoms, or the case definition based on symptoms of what we want to include. These were the main rule-outs, and these are the main reservoirs: dogs, rodents, pig, sheep, things like that. So this is a way of starting a risk analysis to build syndromic surveillance. And try and look at, we have a syndrome, we have a certain amount of visual or diagnostic, simple diagnostic clinical signs, we have a rule-out list, and then we have reservoirs that we would like to investigate. Okay? Does that make sense? Often this is how you start when you have an unknown issue. Very much in wildlife. Talk about buffalo. Buffalo sick with respiratory disease, getting skinny over time, and some are dying, some are not. What are the rule-outs? It's buffalo respiratory thing. What are the list of diseases that could be buffalo respiratory? Right? We could list many if we wanted. And then how do we go about learning about the ecology of that? Sentinel surveillance. We talked a little bit about yesterday. But it's a prearranged sample of reporting sources agreeing to report all cases of defined conditions which might indicate trends, blah, blah, blah. This is a very boring definition. But it's an official definition, so I thought I would give you one. Really what you're looking for is a specific representative sample of a problem in an area of which you're concerned. It's useful when you need a sample to cover an entire population in areas where active surveillance is difficult, right? So maybe your statistics would tell you you need a huge sample to be sure that there's no disease, but you have very little money. So you find sentinels within that to represent that you can afford, and you try and make sure that those represent enough of that active surveillance. And I'll give you an example of that with West Nile virus in the United States. There is a lot of debate about how useful this is for a rare disease. Because if you only have a few sentinels and the disease doesn't happen very much, will those sentinels be appropriately placed to discover something should it occur? So there's much argument over sentinel use for emerging or new diseases. And we get into this in wildlife a lot. Can we do sentinel wildlife surveillance that has enough coverage to know what would be emerging and how and why? So I think I showed you this yesterday, maybe not. I talked about the canary in the coal mine, right? So very Western maybe example this time. But sentinels, these guys were used when there was no oxygen for these guys to realize it was unsafe in the mine, so run out and get oxygen. And so these are the characteristics, though, of good sentinels for public health. Susceptible species, if you don't have a sentinel that is susceptible, that can get sick, then you'll never see it get sick, so it's useless. Right? Stationary population. You want to serially sample these guys over time. So you need this to be things that you can get to. For wildlife, that's very important. Are migratory birds good sentinels? Yes or no? Who thinks yes? For avian influenza, sorry. Migratory, who thinks no? Who doesn't care? Who wants to be a wildlife veterinarian? Okay, then you have to care. Who thinks yes? Who thinks no? Okay, let's talk more about this. So, if you have to be able to repeat sampling individually and see this animal over time again and again, how likely is it that you can repeat sample a migratory bird? Anyone? Likely? Not likely. Not likely, I'm saying. Okay. True. Now, it's not impossible, right? Because we ban birds, we do capture release biologists, so that you can set that up. But if you need a certain sample size to be sure, it's maybe not the best place for your money. Okay? So that's just one example. You need to be able to serially sample over time. Usually when you're talking about human populations, you want to know both an urban and a rural risk, right? Does that make sense? You want to know about the density and the risk of density in your population, things like that. So it's good if you can make this work sometimes in both rural and urban situations. You want it distributed representatively, right? Because there are less than you would have for appropriate statistical design. You want strategic placement to try and maximize the likelihood that your sentinel will get sick if the disease occurs. Does that make sense? Okay? And then, if it's a zoonotic disease, it doesn't matter if this is out in the middle of the jungle where no humans ever go. It may matter for wildlife, or it may matter for us because we're wildlife veterinarians or ecologists, but it may not matter for humans. And with limited money, then you need to think about whether or not this is cost effective. If you are testing for a scary disease in the middle of the jungle, and the point is for public health, there's a bit of a debate about whether that's worth it. Now, we all think as wildlife people, we want to know, and we want to understand, and we want to know where the risks are. But with limited money, maybe it's better to do that in the fragments around the villages rather than in the middle of the pristine forest. Maybe not. There's arguments. Okay? So, sample standards. These are just the categories and things that you have to think about. And for wildlife, these are much different than for normal, easy veterinary medicine or easy human medicine. Right? Wildlife guys, we've got a lot of issues to get through to do our surveillance. And we'll talk more about that today. Diagnostics, same issue, right? Tuberculosis tests. Some of our friends are working on TB in elephants. Is there a valid diagnostic test for TB in elephants? Well, you can do cultures, right? That's valid. Kind of difficult to get the cultures. There are new tests that are available for tuberculosis in elephants that are still being validated. So we trust them, but we're not overly confident yet that they're good. So what about tuberculosis in gibbons? Anybody tested a gibbon with tuberculosis? Primates, right? You do the little eyelid, right? Zubats here. So go catch the gibbon in the wild and do the thing, and then come back 3 days later and find the gibbon. No, that's not good. Do swabs and try and culture. Okay. So how do we do these? And how do we set up systems that will help us validate tests for wildlife so we can do more work? Keep that in your mind always. How can our systems that we create get data to help with test validation? By doing that is the only way that we will get to do more good work for wildlife. There are real issues with these that we did yesterday. Very good job yesterday. I want to make some points about sensitivity and specificity versus predictive value. So these are measures of how good the test is. Those help you determine when you're designing a system, what test should I choose? This is a good test. This is a bad test. Right? The example that you went through yesterday, which test should you choose? There's no simple answer because it sometimes depends on your question. Right? Does it matter more if you have false positives or false negatives? And so when your test gives you more or less of sensitivity and specificity, does that fit your system? Whereas the predictive values are more useful for interpreting the test when you're using it, right? It's asking the question, how reliable is this test answer for this animal? Not should I use this test. That was all about how good is the test. How much does this test determine the truth versus how accurate is my test result for this individual sample? Those are the important pieces of these two information. And this one has a big interaction with prevalence. So what does that mean? So that means that logically, if you look at predicted values, so this is positive predicted value, this is negative predicted value. This is prevalence, So when you have a very low prevalence, your positive predictive value is what? Is very low. Why is that? Can someone tell me? Anyone? When there is low prevalence in a population, very few cases, right? And you get a positive, how likely is that to be wrong? Well, it's more likely, because there are a few cases, so there's more uncertainty around that value. So maybe I'm not explaining that well, but let's go to the negative predictive value. Yeah, no, that would be a good. Let's go. We're going to go through more of this later, actually, in our example. I think this is really important because the believability of your answer is affected by how much is in the population of a disease. Because when there are very few cases, like in this, to find, then a positive may be wrong because the test is not perfect. And the same thing with negative. So we'll talk more of that. This is really important, though, and maybe we need to dedicate some real time. Okay, so databases. For wildlife people, you're going to want to make a database for your surveillance. And that can be a spreadsheet, that can be a piece of paper, a chart, or you can get into Microsoft Access or a database program. One thing I have learned many times over and over is that if you work with really good professionals who build good databases, it saves you endless time later. Make the best database you can in the beginning. Work with professionals if you can. If you're writing a grant, write in good amounts of money for a professional database because it can ruin your program not having a good database. Okay? And the purposes of the database, again, we've talked about. If you can build in reports that are automatically generated, it helps with the speediness of your reporting, right? You don't have to extract the data, do all the manipulation, make a report, send it in. Many of you are now governmental veterinarians. I'm assuming they will be asking you for reports. It may be an interesting exercise to have a wildlife disease database for the government as a project, a combined project, where you can then use this and generate your reports. Might save time, might be very difficult, but it would be something that I would put on a priority list for your initiative with wildlife medicine. And then the issues of analysis. Most databases will not do analysis. Some will, but you have to build that. Most of the time you need a function to extract your data, which you're going to learn more about today in practice, in order to use a different tool for analysis. So it will give you descriptive reports if you build that in, which you should, if you can, but it won't do your analysis for you. The difference between descriptive and analytical epidemiology. Okay, so why are you doing this? What's the objective? That objective is usually political, to find something and do something about it. So what will happen as a result? As wildlife people specifically, you need to think about this. So this is the golden rule. Do not ask a question without knowing what to do with the answer. We're excited. We're wildlife people. We want to go out and collect samples and learn in places where nobody has ever been and learn. Why? Is it because we just want to know what's out there? Okay. That's okay. There's no judgment of that. What if you find Ebola? Is that going to be a wildlife veterinary problem? Or is the Ministry of Health, Agriculture, WHO, Barack Obama, everybody show up on your doorstep the next day wanting to know what's happening, wanting to go sample. Now that may be a good thing, right? I'm not saying that's wrong. But know what you're going to do with the information and the implications of that information and prepare for that information. So there are public opinion, now in the newspaper the next day, Ebola in the middle of National Park. Kill all the tigers. Oh no, we can't have tigers anymore. Kill all the elephants. Right? So there's real issues here, and I know that you guys lived through that for avian influenza, for SARS, things like that, right? Unintended consequences for wildlife conservation. You're not just wildlife veterinarians, you're conservationists as well, right? So it's our responsibility to ask questions and be prepared for the answers in order to deal with the perceptions and the politics of those answers. Otherwise, I found SARS in a civic. Let's go kill 1 million civics. Oh, it was only in one civic. Things like that happen, and that's maybe not the point of our conservation piece of our job. Okay? Very important. Evaluations. There are formal evaluation systems that are international standards, WHO, OIE. They have documents on those websites in your homework that you can find, and we can give them to you as well, where you do evaluations of these systems. And those evaluations have many measurements that end up in the effectiveness, the cost benefit of them, how easy it was to do this. And for wildlife, this is important because it's usually very difficult. Okay? So this is a part of good surveillance standards. And certainly for wildlife, this part right here is incredibly important. Because we have trouble getting funding for our systems, we need the evidence to show that we are being responsible and making good use of that money in order to get more money. And that's the game, right? You want to know about grant writing? These are some of the basic principles before you write the grant. Okay? Alright, so wildlife disease surveillance, why do it? Well, for us, many of us want to know this, right? We want to know natural history. And that's okay. And we've talked about what you need to think about as a result. We know that many other people want us to know this, right? So the whole PREDICT program is about this and this. So often our reality as wildlife people is that we use these two things to get the funding to do this. Because human health has all the money, and they care about these, and so do we. And integrating ourselves into those programs will help us do this, which helps us be better wildlife veterinarians and conservationists. So that's the next funding strategy. Okay? So, participate in One Health. I keep saying that over and over here because you have a unique opportunity, as Chris said yesterday. You have a new cohort of federal veterinarians for wildlife that have been invited into the process. And you did not get, most likely, invited into the process, not all of you, for that first reason. Maybe 3 or 4, but I doubt that the government is paying for all of these positions to know this. I'm not saying they don't care, but they're paying for this. They're paying for you guys here. Okay? Not to belittle or not to make small of this, because we all care about that probably the most. Okay? And then this is always a question you should ask. We are always, or very often, asked, can we set up wildlife sentinel programs? And that is not an easy question. So we're going to look more at that. This is one of my favorite cartoons about wildlife sentinels. This is the Ark in the Bible, Noah's Ark, with all of the animals. And this is a bird, and it's saying, testing for bird flu. It's a sentinel for the Ark. So I love that. This is my absolute favorite. Have you seen this one? It's another one like the Ark, so they put all the birds out on a back raft for H5N1. First time one of them sneezes, cut the rope. So anyway, had to have a few jokes, huh? So again, this is our list. This is the piece of paper you have. The rest of the day, this is your system. This is what we talk about. At the end of the day, I want you to be able to go and say, where did I just get transferred to? And what animals are there? And what are the important issues within that? Okay? Okay, so what time is this session over? 10:30. Okay. So everybody stand up for 1 minute. Stretch, stand up, on my feet. For me, I kind of like to stop myself, but I didn't ask anybody to do that. My cheek. Are there questions right now?
Someone confused between the meaning and the implementing of surveillance and survey. Can you explain our difference between surveillance and survey?
Okay, you can sit down if you want, or stand up. I will sit down for the microphone, but you can stand if you want. So the difference between surveillance and survey. Okay. A survey is a tool to collect information based upon a question. Surveillance is the overall process of watching for something and reacting to it. So surveys are tools that we use within surveillance a lot of times. And survey design and methodology is one of the major tools to do active surveillance. Because you create a study design, you do the surveys, you implement that. It's also a tool used for passive surveillance, where you have some questions and you meet with your diagnostician or your pathologist, whichever, and you do a survey of them. Or local people. How many sick dogs in your village? That's part of surveillance, but it's a tool. The survey is a tool to use to perform part of the surveillance. Does that answer the question? Or did I miss the question? Okay. Are there other questions? We'll talk about survey design as well. Oh, one in the back. Oh, so one here and the front.
Do we have to use sentinel animals for our surveillance program?
Do you have to use sentinel animals in all surveillance? No. Sentinels are a specific instance. So when we had West Nile virus spreading across the United States, we put little cages with chickens in many places because it was useful for that purpose at that time, but that would not be a normal practice. So it is a specific tool used when you need to represent an area because you can't sample enough. Yes, sir.
Can I add to that example tonight?
Please interrupt and add any time, because I'm just telling you my experience.
It sounds like they're interested in sentinels.
Yeah, and I'm going to give a whole example as well to back that up.
Dominic will tell you about sentinels, but just from the Australian perspective, the sentinel chickens are a part of the national surveillance system. So they use them. Australia, like many countries, has a number of arboviruses. So they have what's called a national arbovirus surveillance system. And one of the nasty arboviruses in Australia is called Murray Valley encephalitis. It's very like Japanese encephalitis. It's one of those viral encephalitides. that causes serious problems in humans. And it fluctuates because it's spread by mosquitoes up and down throughout the year or across different years. And so what they do for that is that in Western Australia, where I come from, Perth, in the north they have sentinel chickens. So they pay people to keep chickens. So you'll be in a small town or a village, they'll give you 20 chickens, and they'll give you some feed and pay you a little bit to keep them alive. And then every month the Ministry of Health send teams of people up to the north of the state, because it's usually in the north where the disease exists, and it spreads down to the south. And so what they do is they bleed the chickens every month. So they take blood samples from the chickens every month, and then they bring the results down. If the chickens seroconvert, then it gives them an early warning that there's Murray Valley encephalitis activity, because it doesn't happen all the time. So then they put out public warnings in the newspapers. So it works very well that way. They also do mosquito surveillance at the same time. So
that's great. That's great.
And also in northern Australia, I think in northern Queensland, they have sentinel pig populations for Japanese encephalitis, because they don't have it in the country. So it's across that northern area. So it's used standard practice.
And I think there are Nipah pig sentinels here, right? Correct? Through Southeast Asia in general now? I thought I heard that. Okay, maybe not. Sorry.
Also with avian influenza, when you read around the subject, there's quite a lot of information about sentinel chickens. So you can vaccinate a whole flock, and then you might leave a few unvaccinated birds in a flock. Now those birds are going to tell you if there's virus circulating in the area, which you might not find because of the vaccination policy. So if the unvaccinated birds die, then they'll take them for testing, and they'll say that there's possibly avian influenza. There's a number of them.
Yeah, so there's many good examples, but so it sounds like Australia has really incorporated this into their national programs long term, whereas others may or may not. So, okay, there was a question up front? No? Okay. Okay. I am going to now try to do, in 45 minutes, 3 full examples of projects that I have worked on. So I spend most of my time on surveillance of wildlife. And one is in apes in Africa. The other is in carnivores in Africa. Sorry, we're giving you the non-Thai examples, remember? You're going to give us the Thai examples later. And then in the USA, using zoos, for those of you who are zoo people, using zoos as sentinels for the spread of West Nile virus in the USA. Okay? So, I have a lot of slides. I will go fairly quickly, because I want you to, I'm going to tell the story, but I want you to think, as I tell the story, about the pieces of the surveillance. So you look at your piece of paper and make sure I cover the pieces. It may not be in that order of the surveillance system in that, okay? That's the point of this exercise. Gombe National Park, Tanzania. Chimpanzees, made famous by Jane Goodall, Dr. Jane. Okay, so wildlife people hopefully know about that. Made more famous by Chris when he was a student. Okay, maybe not famous, but he was a student there. Oh yeah, that's fun. So diseases in apes, right? People believe that because we are closely related to apes, that there is disease transmission going back and forth between people and apes. In small island fragment conservation areas, especially, with ecotourism researchers, many local people, right? Chris taught us about that yesterday. This is another example of that. And actually, I started with these guys, with the mountain gorillas, and then moved over to Gombe, because it was a smaller park with a lot of problems and a little bit easier to test some epidemiological methods than the difficult place they were working. So it was easier. But there's a lot of debate over whether those diseases come from humans or whether they're just part of the natural diseases floating around. because we don't immobilize apes most of the time. Mountain Gorilla Veterinary Project does. I don't know if in Southeast Asia the orangutans get mobilized a lot, or gibbons, but we know that in study sites for chimpanzees and gorillas in most places, there are many issues with immobilization. As you may know, it's not always safe. Chimpanzees can run up trees and fall asleep and fall. You need nets. They have friends. They have friends who don't like to watch them get darted if they notice, or to fall asleep, and they may attack you. They have researchers who have spent years habituating them, who don't like and or are afraid of veterinarians, and are afraid that you will unhabituate them and they will not be able to study them. There are a lot of politics and a lot of issues about immobilization of apes. MGVT is a very big example of very forward veterinary medicine in the ape world. Okay? The ape research conservation. So we've been trying to use non-invasive diagnostic tests, fecal, urine, saliva, to do surveillance, syndromic surveillance on these apes. So in Gombe, it's a very small park. Well, let me back up. So this is a publication that's by Leondertz et al. In Biological Conservation that lists the absolute definitive diagnoses at one point, and there were very few that had been confirmed at that point. So every time there's true confirmation, we try to publish so that we know these are the diseases, and then maybe also survey local humans and try and do the molecular work to show that they're going back and forth between humans. It makes sense that they're going back and forth between humans, but it's very hard to prove. Remember the cohort study where you need things in the right order, causation versus correlation? It's very hard to do cohort studies and sample humans and then watch them go into the forest and then sample apes and watch them get sick in the right order for that. Very difficult. So Gombe National Park, Tanzania, does everybody know where Tanzania is in Africa? East Africa, I should have had an African map. East Africa, just below Kenya. This is Lake Victoria, Kenya, Uganda, Rwanda, Burundi, Tanzania. Republic of Congo is here. Okay, it's on the western side of Tanzania on Lake Tanganyika. And it looks like this. It's on the Rift Valley, which is a gorgeous place with what forest is left, which is there's not a whole lot of anymore. It's beautiful forest, but there are these large fishing villages and high dense human populations around the park. So a lot of interaction. 35 square kilometers, this park. Not very big. With big villages on each side. So this is the park. This would be the lake. This would be the rift, or the ridge, the mountain range. There's big villages here, mostly because when they made this park, they kicked the people out. This happens all over the world, right? And the famous chimpanzees of Jane Goodall are in this middle community called Kasekela. There's another community called Matumba here, smaller, to the north. There's about 72 individuals here now, about 20 here. And then there's an old population down here that was mostly wiped out due to a battle between the chimpanzees and maybe disease. Disease played a role. That is not habituated. That they're still figuring out how many there are and don't know much about them. Chris has good stories of all sorts of things up in this community when he was a student. Maybe he'll tell us at lunch. But this is the park, and there are many people, and there are many disease outbreaks in the park. We know that there have been outbreaks throughout the years. Jane Goodall's study has happened for 50 years, and we have continuous data on the entire population for 50 years. That doesn't happen in many wildlife populations. And we know that they had illness, aggression, injury, orphaning, maternal disability, things like that. But that illness has caused the most deaths that they've watched in 50 years over the park. And the question is this due to people, or is this due to just natural disease? And if it's due to people, how do we prevent it, and how do we manage it? If it's natural, people will likely want to leave it alone. Even though it's so small, you kind of have to manage it. Okay, so this is, when you look at the illness, These are the kinds, again, we don't have diagnoses. These are the kinds of illness. And you can see that epidemic respiratory diseases are a big thing, and wasting diseases are a big thing. So this is descriptive epidemiological data from behavioral research, not from veterinary research. We know that they watch the population, so the females are in red, the males are in blue, and the two biggest sharp declines in the population have been associated with things that look like outbreaks of pneumonia, of illness, of respiratory disease. And then this may have been also polio disease at one point. They never proved that. So what we did is we built a system, a syndromic system, to collect all the information we possibly could from these chimps, walking alongside next to the behavioral researchers without touching them, unless they died, and then we did necropsy. Okay, so this is our scheme, and we replicated this now in baboons partially, and we're starting to work with the humans as well. So we're building this system in chimpanzees, baboons, and humans. There's a lot of interaction between these three populations. And for that, we have 4 categories. We have observational health data. So next to the behavioral normal, these guys are grooming these guys, and this one played with the other one. We say, how did they look? Did they cough? Did they have diarrhea? Did they look emaciated? Do they have wounds? And we have a separate data sheet for that. We do fecal collection for parasitology. We started that because it was something we could do, not because we believed it was necessarily important. So I ask you, start with the end in mind. Why do this? Well, for parasitology, it was because we could. Turns out there are many interesting parasite problems, and it's a good thing that we did that, even though we had no specific question. Well, we had some, and Chris and other students had kind of given preliminary data that said maybe there's some issues, but it wasn't proven over time. Pathology. Proper necropsy. When you're following apes, it's not always easy. When they get sick, they go off alone in the middle of the woods to die alone. Right? You have to specifically track them and watch them die and know where they are, and then get a team to them immediately before the decomposition is too much in order to get good samples. And in a place very, very, very remote, to have the equipment, the trained people, the cold chain for storing things, the proper sample preservation materials. Look at your little sheet. All of those issues I'm bringing up are things that are very difficult to do in this very remote situation. So we had an entire initiative on training, building infrastructure, and long-term storage of samples. And then we built many partnerships for non-invasive diagnostic test validation. So since we can't get blood, we can't just do serosurveys. We need other diagnostics. And it's non-invasive. So this is our database that we built. This is our sheet. We have a chimpanzee health data sheet. And the guys follow them, and they do the health sheet along with the behavior. And we've trained our guys. So you guys have ranger-based monitoring that you've had discussion. This is our ranger-based monitoring system. Okay? So syndromic surveillance via ranger-based monitoring. You train them to be your sentinel observers, and they come back and give you baseline data, many normal health conditions. But then when they see something different, they come and tell the veterinarian, who goes out and does in-depth investigation. That's its own kind of sentinel surveillance on a syndromic kind of approach. People with me? See how these different issues come up and you combine them? And then we enter the data into our web-based database, and it comes out with reports for us when we ask it. Parasitology, over the years, we have found many parasites that are important at very high prevalence. And we found that it's having a big impact on the health, and we're trying to understand that the emaciation disease is very correlated with observable signs of diarrhea and of high burdens of worms, many of which are pathogenic. So we have the pathogenic with the asterisks here. And we have a large esophagostomy problem. And when you do necropsies, you see these big granulomatous nodules in there that are actually in the abdomen where they know there's ascites and other kinds of issues. So the worm burdens are absolutely huge here and are very associated with this emaciation sickness. We started to look at seasonality, and we've started over the years. We've been doing this for 8 years now, and you start to see the seasonality and what is normal. You can't determine an outbreak unless you know what is normal. So our goal is to create baselines so that when we see something different, we know, we should investigate. Right? Yes, sir.
How often do you take these samples?
Fecal samples, so we have a study design. It is active, and we want to get a monthly fecal sample on 80% of each population. And we don't always hit that target, but that is, we have power calculations for that and things. But that's our study design. And so a sample consists of the sheets, the behavioral health sheet, and a fecal sample, and sometimes a urine sample or a saliva sample, depending on the system as well. So we have the behavior, what does he look like that day, and then we have the diagnostic sample with that. That consists of the sample. And there's arguments about, should you watch all day? Can you look at them in 2 hours and know how they feel? What's the time frame that you should fill out this data for? Our parasitology collaborator, Tom Gillespie from Emory University, has looked at about 13 different field sites with apes and has not found Cryptosporidium or Giardia in any of them except for bone bear. And we have fairly high prevalence of this. And this will come into play later when I tell you that we also have SIV. Does everybody know what SIV is? Simian immunodeficiency virus, which is the precursor of HIV. That supposedly does not cause illness in apes or in non-human primates, but is killing our apes like it's AIDS. And those apes also have Cryptosporidium and Giardia. And if you know about HIV, with the cofactor of Cryptosporidium Giardia, you start to look at an emaciation disease like we're seeing high prevalence of here as well. We haven't proven all of this pieces yet, but we're working on it. So we have high protozoan, and we've now started an environmental investigation to look at goats in the villages, dogs, there aren't many cattle, the people, the baboons, the monkeys, the watershed, sampling in the environment, try and figure out how to manage this risk, because it's also a human risk for people who are there. We did this necropsy training. We built a module of which I have one disc with me that we're trying to put on the web that is downloadable for everyone. So we can either try and make copies of that disc, I can leave it and you guys can make copies, or it will soon be available on the web to download. It has a manual right now, and I would love translation from somebody, in French, English, and Swahili, because it was made more for Africa. But it is still useful for gibbons and monkeys and orangutans and things as well. It has a field manual. We trained all of our high-level scientific staff to do proper necropsy with proper PPE and safety, sample preservation. And these are all of the park vets in Tanzania. So this is your group in Tanzania, plus some researchers that all did this training together. And the disc that we have also has a graphic training manual where you can go through the training process as well. And we love feedback on that, so let's talk about how to get that to you guys, if you don't mind. We are now publishing our series of 12 necropsies that we've done, and this is how we also found that the SIV was causing AIDS-like illness, because there are pathologists, and pathologists in the room. If you're still here today. Are you still here today, pathology people?
Sorry.
Okay, we still have a couple. You are very, very important, because we as veterinarians know how to do necropsy, but do we know how to do it right? Pathologists are going, no. But it's important when you have very little ability to sample wildlife, very few specimens. It's important to do this right and to get all of the samples and to get many replications of the samples so that you can archive them and have that information. And the wildlife pathologists are very important to that, and we need more integration with wildlife pathology. So our wildlife pathologist is working on publishing this. And then this is the AIDS story. So this is in Nature. And we've been watching for 10 years SIV. There's a fecal test for SIV in AIDS. And we know that the prevalence over those 10 years has gone up significantly. Right? So that's from 5 to 20% almost in those 10 years. So we were looking at the behavioral data and the demographic data, right, the population-based data, trying to look at survival curves and survival analysis. Just on population data, not on illness or mortality, just mortality. And fecundity. Does everybody know what I mean by that? So how successful they are at giving birth and having offspring that survive, and also death rates. And we found that the SIV cohort, remember, we have a risk factor, SIV, or we can do this retrospectively or prospectively if you want. But we have SIV, and we want to know if there's a difference between the ones that have SIV, the 20%, and the ones that don't, in how long they survive, and how much they have babies, and how much those babies live. And there is a significant difference in that SIV cohort, saying that they don't live as long, because it's for 50 years we have data on every individual, and that they don't have as many successful living offspring. Now it's a small sample size, so the statistics are a little bit on the edge because the sample size is so small. So we were having big statistical arguments over this. When we had 2 animals die, and they died and they looked like AIDS patients. When they looked like AIDS patients, our pathologists worked with our National Institutes of Health HIV researcher, and they did blind trials where they put the chimp tissues and the human tissues from HIV and SIV next to each other, and they completely agreed in a blind trial on every one of those, of which was pathogenic, which was not. And then they looked and they said, wow, the chimpanzees are just like the humans. And I'll show you a little bit of that. So we know that in the past 9 years, the rates have gone up. They have been, when you look at the demography, they're transmitted both horizontally, sexual, and vertically to the babies. So we know that about HIV, right? We know that there's a 10 to 16-fold increase in mortality risk or decrease in survivorship, right? We know that the females are less likely to give birth and have higher infant mortality. All of these are very much like HIV. And then we know that pathologically, SIV infection is associated with progressive CD4 T-cell depletion, right? The main marker of HIV. Lymphatic tissue destruction, and an AIDS-like immunopathy. There's wasting disease. So all of this was without ever touching a live chimp. And this is, for those interested, pathologists, immunohistochemistry of normal chimpanzee and human spleens, right? So you can look at, these are 3 different chimps, 2 chimps and a human, sorry, and the different stains. So normal morphology. And then you can look at the T-cell depletion in the cases, again using multiple stains across multiple chimpanzees. You can obviously see the difference. So in the magical pathology world, they did their tests, their blind tests together and came up with concordant results. But then, in the not as magical, in the measurement diagnostic world, it was consistent as well in terms of quantitative image analysis, right? So the quantitative counting of those images, where we had a human, these are, so again, T cells, right, or CD4 cells, human chimpanzees that were negative, positive, a control Rhesus macaque, and a sooty mangabey, which should not get sick, right? They're a carrier that's never gotten sick. So you can see that our cases were also, so that's kind of the evidence in the Nature paper is there if you want more. But that between the observational health, the survivor curves, the demography that we had, the behavioral observation of wasting disease, the SIV fecal results and then the pathology work, we have this syndrome that we've been able to look at and characterize. And to our knowledge, it's the first time that pathogenic SIV has been found in the wild, and that brings up many issues of HIV evolution and those kinds of things as well. So we're exploring that further. This is to look at, we've gone back in some of our health behavioral surveillance, and there's a lot of significant things. The body condition scores, the wounding, the lameness, the diarrhea, in terms of their association with this SIV positive cohort. Okay? So that's an example. There's many, many, many partners, and we've had many grants from these partners trying to keep this together. Paying for long-term wildlife surveillance is not easy because people don't want to pay for you to just watch. They want to pay for exciting results. So we built this, and this has come out of this, which is now very exciting. It was somewhat boring at first. Okay, that was number one. And I'm not going to ask for questions right now. We can maybe do that later because I want to show you all the examples. Okay? Number two, Serengeti. So if we... Does everybody know where Serengeti National Park is? I don't know if you know that. So, sorry I don't have the African map. That was an oversight by me. But in Tanzania, the same country, up on the north, on the border with Kenya, and this is Kenya, this is Tanzania, is Serengeti National Park. This is the Masai Mara, two very famous parks in East Africa. Famous for the wildebeest migration that circulates around. And the wildebeest are not the thing that the tourists come to see. It's all of the carnivores that come to eat the wildebeest that make it so famous. And so they have African wild dogs, leopard, cheetah, hyena, lions, in very large numbers. This is a park isolated by a huge human population and different kinds of culture. On the west side of the park, you have agro-pastoralists. Agro-pastoralists, we'll describe that. On the east side of the park, you have traditional pastoralists, like the Maasai. So on the west, these agro-pastoralists live in high-density settlements, high-density villages. They're settled down. They're ethnic, multi-ethnic communities, a lot of immigration into this area. They have livestock, mixed crops. They're settled. And a lot of domestic dogs. This is a group at a vaccination line with hundreds of people bringing their dogs for rabies vaccination. On the east side of the park, in the pastoralist area, you have remote, low-density communities. It's traditional Maasai pastoralism, very cattle-based culture. Low density of dogs, but they exist. And a lot of mixture with wildlife, right? Because the pastoralists share the land with the wildlife reserves. There's no fence. There are no fences at all, in general, in East Africa in wildlife. There are a couple, but very little. So the borders are called soft edges, not hard edges, right? There's a little mixture and overlap with the animals in many places. This is just a picture of lion tracking with some collars, some radio collars of trying to understand the movements in and out of the villages of these carnivores, but it's just to show also that there's no fences. So we know that there are disease problems in this ecosystem. Wildlife to human, zoonotic diseases, wildlife to domestic animals, things like malignant catarrhal fever, if you've heard of that. And we know that the humans have posed many threats as well. So this is an ecosystem health problem here, and there are many issues within that. Traditionally, renderpest has been an issue, right? And it's just been eradicated from the world. If you're following those websites, FAO, OIE, the big victory of renderpest eradication, right? And that's the second disease to be globally eradicated after smallpox. Big veterinary victory. Well, renderpest used to drive the whole ecosystem because it killed so many cattle and killed so many wild ungulates that there was no migration. Thus, there were no large amounts of predators to eat those animals. And the ecosystem was very different because there was less grazing, which changed the fire management, of the park, which changed the habitat for the people, for the grazing of the people. You see how it's connected, right? So this is kind of just a, the picture of the different connections that when they eradicated rinderpest, it started coming back to its equilibrium. So it had a huge impact on food security locally, habitat viability, population conservation, and especially carnivore conservation, as we have said. So there have been other issues for the carnivores as well. Rabies and distemper virus being two very important ones in these communities. So carnivores, these wild carnivores, do not do well with these diseases, just like our domestic ones. The Ethiopian wolf is a case study of a highly endangered carnivore that has been almost wiped out by rabies numerous times, and there's an active management and vaccination campaign going on in Ethiopia to save these guys. But there's publications with many different outbreaks, and this is by Cleveland, Sarah Cleveland from Glasgow University in veterinary microbiology, summarizing the devastating outbreaks historically in these African carnivores, Kenyan carnivores. So in Serengeti specifically, the wild dogs became locally extinct in the 90s when the last pack was wiped out by rabies. And it continued to have outbreaks in bat-eared foxes. And then in the early 90s, there was a neurologic disease that killed 30% of the Serengeti lions. And that got people's attention and became an issue. And they started investigating what this was. And they actually found out that the lion issue was distemper. But meanwhile, they were working, the conservationists were working with the local veterinarians, the district veterinarians, and public health people to investigate rabies, because they really thought it was rabies at first. And the story I'm going to tell is about rabies, not distemper. But there's a distemper story as well, which is that during an El Nino year, there was a higher tick population that year with babesiosis that was a cofactor with distemper. So it had the right ecological conditions that year to where they got a dual infection, co-infection, that wiped out 30% of those lions. But meanwhile, everybody started worrying about rabies. So this project was created called the Afya Serengeti Project, and that's just Swahili for health. And the goal was to understand the role of rabies in the ecosystem. When they looked at the people, they found that for every one case of rabies in humans that was reported, there was at least 10 more that were not reported. And in some places, 100 more that were not. So rabies is that neglected disease, right, of veterinary medicine. We all know that. So what they decided to do is figure out, at that time I wasn't involved, I got involved about 2 years later, but they decided to figure out what's the ecology of rabies. Everybody says you cannot eradicate rabies because of the wildlife vector, the wildlife reservoir, right? So is that true? Can we manage rabies around this ecosystem? Or was there just so much in wildlife that we'll never get rid of it? And we'll just have to do vaccination forever? So that was question number one. And the second is it feasible and cost effective to control it through mass domestic dog vaccination? So not talking about vaccinating the wildlife, but talking about vaccinating the domestic dogs in really a buffer circle around the park. And is that a sustainable program? So in order to do that, it's really a surveillance question, right? So this is the applied part of the surveillance. So the hypotheses look like this. If it's really just about dogs, then if you cut out the dogs, then you don't have the dogs going to wildlife and dogs going to humans, and you can stop rabies. But if it's not just about the dogs, and the wildlife play a significant role, then by getting rid of the domestic dog risk, you still have a very good link here, and it won't necessarily matter, right? So that's the question. So, this is longitudinal prospective surveillance of the wildlife and the domestic dogs in and around the park. So we set up a semi-active surveillance system because it was very difficult to meet the numbers that we needed to make statements about this huge park. So what we did is we told all the rangers, again, ranger-based monitoring, we told all the rangers, all the tour guide operators, all the people that worked in the park, that if you see a dead animal, we want to know, and we'll come do the necropsy. So it was kind of passive, right? Because it wasn't a statistical, we need 37 lions. But we also had the statistics done where we were trying to find ways to reach the numbers that we needed for statistical significance. So it was kind of a combination of the two. But what we found over numerous years is that the domestic dogs were this curve. And this is the east side of the park in the pastoralist community, and this is the west side in the agro-pastoralist community. And that cats play more of a role, and we know that cats are a very underappreciated issue with rabies, domestic cats, sorry. And then these are the wildlife species, and you see how very little there are. Spotted hyenas, jackals, mongoose, bat-eared foxes, honey badgers. There's some in the jackals, right? Most domestic dog-like things, but very little. So the point was, this looks like it's a domestic dog thing with not much of a wildlife interaction. So let's keep moving, and let's do genetics. So in our surveillance, we took the samples that were positive, and we looked at the genetics. And this is the family tree of rabies in Africa. And we found that all of them were very similarly associated with the African domestic dog variant. None of them were associated with the wildlife variants. So another piece of evidence that said this is about domestic dogs, not about wildlife. You would have expected to see some that looked like wildlife, right? If the wildlife reservoir was spilling over into the domestic dogs a lot. So, we got funded through a National Science Foundation grant, vaccination campaign. And then this is the vaccination villages on both sides of the park. And over time, we've been able to show that there was high persistence in high dense dog populations surrounding the park, that there were sporadic cases in wildlife in the park, but not sustained outbreaks in the park, and then kind of occasional sporadic where there were medium amounts of domestic dogs in the pastoralist communities. So more evidence for that. So the question is, we really started thinking, yes, this is about the domestic dog. This is through surveillance. And then decided, okay, let's try the vaccination campaign, and if we get rid of the dog, in terms of risk, then we should watch all the rabies go down, right? And see really not much more rabies at all, maybe a little bit. So we created teams and we vaccinated in a 10-kilometer buffer around the park, between 30,000 and 60,000 dogs a year, going on about 8 years now or so. 160 villages. We had teams of people, and it turns out they look like feral dogs, but everybody actually owned them and claimed them. They just run around so you would never know who that belongs to, but they all know. They all have names like Saddam and Simba and things like that. Simba is lion and Swahili. And we kind of showed in the cost benefit over time that to do vaccination in dogs is much cheaper than doing vaccination in people after they get bitten. So it's about $2 a dog to vaccinate for prevention, and over $40 US in treatment of a human. So overall, the cost benefit, you can do the dogs much less expensive than the humans, and obviously it's better because it's prevention. So the question was then, are there independent wildlife reservoirs that will keep this going? Can we really get rid of it, or can we just control it? So this is our team, and our team went village to village and worked with the district veterinary officers and the district registrars, and they gave them little vaccine certificate cards from the owners. Usually the kids got stuck taking the dogs and walking very many kilometers to get these dogs vaccinated. Now in many villages there's a school holiday on vaccination day where the kids get let out and they go and take the dogs, maybe 20K, and vaccinate them for free, fit them with collars so that the next day we can drive through and try and estimate the coverage of the vaccination, how many dogs have collars versus how many don't. And you want a high, 80% or so vaccination coverage for herd immunity. We took blood and did serosurveillance to see how these dogs were reacting to the vaccine. This is part of whether you vaccinate every 1 year or every 3 years. Cost benefit, again, the efficacy of the vaccine in these dogs. And these kids came from everywhere via every different way of bringing these dogs, and they still do this today. It's very fun to watch. On the east side, where the pastoralist communities, they don't live in settlements. They move. They're hard. You can't just show up in the village and say, hey, everybody, come get your dog vaccinated. You have to find other ways. And so what we found is that a combination of holding a central point where there are many different bomas on a seasonal basis versus tracking them down and walking from boma to boma across the landscape to find them was the best, most efficient way to do this. So it's a different strategy of control that our surveillance helped us assess and figure out. So the benefits have been that in those 5 years, 400 vaccinated dogs were bitten by suspect rabid animals that did not convert to rabies. Right? So we know that dogs continue to get bitten, but that rabies, if it's in the wildlife, is not being transferred to those dogs and perpetuated through the cycle, and that of those 400, at least 200 would have probably developed rabies. So that's one piece of evidence. We know our wildlife surveillance has gone so that we see very, very few positives now. For about 5 years, we had no positives until last year. There was a mongoose just outside our research house that was rabies positive. So that was interesting because it made us think, what are we missing? And that's always a challenge, is to get the right thing. And the wild dogs have come back. There was a remnant pack hiding, and they've now returned, and without the threat of rabies, they're doing well. We're not saying that it was completely all about rabies and that it was our program that brought them back, but it does correlate. It's a coincidence that they came back when the rabies went down. We know that rabies has almost gone down to nothing in the vaccinated zone, and we know on both sides, the east and the west. Tanzania is now one of the 3 demonstration projects for the WHO for their attempt to eradicate rabies on a countrywide basis. And this project actually was a big piece of evidence for that. So this is a wildlife outbreak helping demonstrate to WHO that you should try and eradicate rabies. And that's kind of a victory for us in the wildlife and veterinary medicine arena. And the Gates Foundation has given $10 million to try and eradicate this. So we continue with our surveillance, doing postmortems, doing serosurveys, dogs and wildlife, tracking everything back to the village. We found many cattle, many donkeys that were positive for rabies as well in these tracebacks. We monitor the populations, the contact between wildlife and domestic animals over the line. How many wildlife are outside the park? We do transects monitoring the contact and the spatial variation of those animals so we can see the potential risk of exposure. We validated field diagnostic kits that you can do rabies tests, as Chris was showing yesterday, in the field next to the animals, in a laboratory that's in a remote place, and in quick, timely, cost-effective manner as a result of this. And now we're doing education and awareness campaigns. So there are many, many, many people in Tanzania and all over that have been part of this. And the vaccine companies donated the vaccines to us for free. They have a program in Europe and in North America where every vaccine they sell in a small animal clinic, they match and give one to the wildlife projects. And we're trying to stimulate them doing that in more places around the world. So I plant that as a small seed planted. Okay? So that's number 2. Let's quickly do the zoo-based one. Okay? Arboviruses. You guys are familiar with those here? You have mosquitoes in abundance, that's what I hear. West Nile virus, being a toga virus, inflavavirus, not a toga, but a flavovirus, is one that is of particular concern because in 1999 for us, it was introduced and found in New York State on our East Coast. This is just a spread of kind of a basic descriptive map of arboviral prevalence around the world in this family. flavivirus, sorry. So this is a lot like Japanese encephalitis virus. It was first discovered, I think, in 1942 in the West Nile region of Uganda. It is transmitted by mosquitoes and other ways we found out, by water, by feces of sick animals, but mostly mosquitoes. And usually lives in this ornithilic cycle of mosquitoes that feed on birds. I've got somewhere a slide with all the mosquito species, sorry. And accidentally at times when mosquitoes interact with things other than birds, has caused disease in a lot of other animals, but most of which have been people and horses, but then many other species now over time as well. Here it is. So over 40 mosquito species. Now this list I think is like at 120, something like that. So it's very viable in many different types of mosquitoes. It causes severe febrile illness in a very small percentage of people who get it. Most of the time it's just a flu-like illness, a fever of unknown origin syndrome. But it can cause West Nile fever, which leads to rash, lymphadenopathy, and encephalitis, and death. So it was a really big deal for us when it got landed in New York, and there was this unknown outbreak in New York State in 1999, and the zoo pathologist at the Bronx Zoo, WCS, in New York, actually followed the diagnosis when many of her birds were getting sick. They thought it was St. Louis encephalitis, which does not cause disease in birds. And she, Tracy McNamara was her name, did not believe that it was that because it was killing zoo animals. And so went to the Army and helped investigate it more. And they found the group of CDC, our Ministry of Agriculture, and the zoo and the Army all did the diagnostics and found that it was West Nile virus. It proceeded to spread in the next 5 years all the way across our entire country in the United States. But in 1999, when I was just finishing my residency, I moved from here, where there was some disease, to Chicago, here. And we knew that it was coming. And so we worked with the CDC to set up a sentinel disease program using our 220 accredited zoos in the American Zoo and Aquarium Association to see if we could provide a layer of data to the national surveillance system. So you have humans, you have horses, you have wild birds dying, but what about these sentinels? Can they help detect this in an area before you see a human case, before you see a horse case? That was our question. Our zoo was a very small zoo, and we had many different trap sites, and this is all the positive in the red circles, and we had one place next to our flamingos, which are highly susceptible to West Nile, that never had West Nile. But everywhere else in the zoo had West Nile virus. So we had a meeting with the CDC, and we talked them into creating a partnership where they paid for our surveillance system, and we were testing the hypothesis of whether we could be that added sentinel for the spread of this disease for public health. And we had numerous hypotheses. Can zoos increase the preparedness of our public health infrastructure? Can zoo surveillance data serve as a source of natural history as we learn about the emergence of this disease? What kind of species will be affected? We found about 150 species. We found reptiles. We found birds, mammals, everything, elephants. Can zoo surveillance data add robustness in the face of an outbreak? In other words, can we help with an outbreak? And can we be quick? Can we be quick enough to help public health? So we were interested in the ecological research. We were interested in zoos being prepared because it was killing many animals on zoo grounds. And these are endangered species and all of these kinds of issues that we deal with. So we had a big working group, or many. I tell you on your sheet, it says figure out who wants the data. Under point number 1, we figured out everybody wants the data. So we got them all to help us pay for it. And we wanted to do serosurveys, watch for dead animals and do the necropsies, and actively look at clinical cases that look suspect as well. So serology of normal animals, clinical cases, and dead animals. We wanted collection animals in the zoo, and we wanted wildlife on zoo grounds. Okay? And so we built a system that looked like this. We worked with the University of Cornell Veterinary Diagnostic Lab, who had the test, and not very many people in the world had tests at the time that were valid for this. and then we built a system with a database where then we reported to the zoos and all the local public health authorities who then would respond to the disease. I'm out of time, so I'm going to start going really fast. Our database design collected zoo information for baseline data, test and test result information, and animal history on vaccinations and the whole history of the animals, because we wanted to create a system with archived material and archived health information. We made it user-friendly after about 5 years of being really not user-friendly, so people did not want to enter their data because our database was bad. Then we found a foundation who helped us create a good database, and magically people started using it because it was easy to use. Huge lesson, professional database people. We had case definitions for what is a virus positive versus what is a suspect. The virus positive was based on the CDC case definition of PCR and virus isolation. Our suspects were clinical serologically positive animals, but that didn't fit the national regulatory case definition, but fit zoo case definition of, hey, we need to do something. These are sick animals that we need to help. So we had two different case definitions. And then we had a reporting structure, as I've talked about, but we made a deal with CDC about our confidentiality. So when the Bronx Zoo found West Nile virus on zoo grounds, it was in the front page of the New York Times, international news. Horrible human disease found at zoo. How many people you think came through the gates in the next 2 months? Not many. They almost went bankrupt. So we tried to make a confidentiality agreement that says, let's do this in a way that if we're helping you, help us stay alive and open. So just some quick things is we sampled from 2001, or 2000 actually, all the way through 2006. Our samples range from 250 samples over 200 zoos, all the way up to 6,000. Actually, these are animals. We had multiple samples per animal. And then as the outbreak subsided over the country, it went back down. We sampled over 16,000 animals. We found fairly high prevalences over each year. These are epidemic curves. You're going to learn about this tomorrow, where you start putting your cases over time and look at the shape of the curve. So these are animals tested. These are positive. We did it by class, so avian, mammals, reptiles, and we did it by collection animals, zoo animals, and animals, wildlife found on zoo grounds. We looked at over the time of the year, and we found that the most activity was consistent with our public health data. Then we looked at seroconversion. We looked at the serology and the sick animals that don't fit the CDC public health case definition, but fit our definition of, sick animals that we care about. And we did the same with them. And we did those for animals on zoo grounds and collection animals. And then we started making maps. And to preserve confidentiality, we didn't put the dots on the map for each zoo, because you would know then who has positive. But we did it by our states. So you can see these are positive states. So there may be 7 zoos in this state, and one of them is positive. So it's confidentiality. But it worked because our local response was at the state level and local level anyway. So they did not need specific information. Now this is the secret map, and this data is unpublished. We're working on publishing it right now. So this is actually the intensity, the number of cases, by the specific zoo point on the map. So you can see that the East Coast in the beginning, where the outbreak started, was really bad in many zoos. And then as it spread across the country, we have less zoos. So less sentinels out here. Less information. Question of whether we're useful sentinel or not. We're very good sentinel here, and pretty good here. But here we did not have enough zoos to really help public health very much. And we found this in only 4 zoos before public health found it. So on one hand we said, yes, we can find this before people get sick and tell you that West Nile virus is here. On the other hand, it only happened 4 times, so cost-benefit, was it worth the money? It was to us. And then we started looking at descriptive epidemiology. So this is the size of the samples and the positives. So this is antibody serology positive, this is virus positive, and the amount versus the sample. So you can start to do that. You can start to do it by class of birth. So you can start doing natural history. These are all the different classes in 80s. and you can start to look at the types of positives. So the bigger the pie, the more positives, and then the pieces are the different classes. So it's, again, descriptive natural history of the outbreak. And then we've got mammals, so African elephants, alpacas, kangaroos, fruit bats, seals, llamas, sorry translator for all of these different kinds of wildlife, pandas, reindeer, squirrel, water buck. So we ended up with 150 some species. So that is an example of sentinel surveillance using zoos, and we are still doing the statistics to show how much we were useful to the public health system. We know that we learned a lot about natural history and ecology. We know that we did help, but we don't know how much. So that's the still to be continued story. I'm sorry I used 5 minutes of the break. But hopefully you see 3 different examples. One in apes, syndromic. You can't touch them, but we changed how you think of HIV and the evolution of HIV. One that was a rabies project in carnivores that ended up being a demonstration project for the WHO for eradication, and one for an emerging outbreak in our entire continent using zoos. And so we like to make the case that wildlife can play a significant role in public health and in these emerging diseases if you find the money and do it correctly. Thank you, and I think there's an announcement. Okay. So over the next day or 2, feel free to ask more questions about this. I'm sorry I rushed, but I wanted you to see the example. Thank you.
Thank you very much, Dr. Dominic. ตอนนี้เวลา 10:40 นะคะ ขอพักเบรก 10 นาที ก็คือเดี๋ยวมาเจอกันอีกครั้ง 15 ค่ะ งั้นเดี๋ยวเจอกันอีกครั้งตอน 10:55 นะคะ ห้องเบรกเป็นห้องเดิมคือด้านหน้าห้องนี้นะคะ ค่ะ